Hello everyone, I'm Dr. Sandeep Sharma and I welcome you to this case discussion that we are going to have on a topic which we frequently see, but we have a tendency to ignore it, and I'm going to do a clinical as well as a theoretical review of the topic. Let us first have a look at the actual case. So the case is a term baby. 38 weeks of gestation baby was born through normal vaginal delivery. The baby had a birth weight of 2850 grams. There was normal Apgar score. The baby cried immediately at birth, but the baby was diagnosed with bilateral cleft lip and palate. There were no other gross congenital malformations, and the cause of cleft lip and palate is under evaluation. The baby has been started on tube feeds. Have a look at the patient.
So this is the term appropriate for gestational age baby, male child, who was antenatally diagnosed with having bilateral cleft lip and cleft palate. And this is the case that we have talked about. Let us discuss briefly about the management of these patients. Let's discuss cleft lip and cleft palate inside out.
Now that you have seen the patient, we know the topic that we are going to take up, that is cleft lip and cleft palate. So what is cleft lip? What is cleft palate? Usually both of them tend to coexist, but there are many patients where there is isolated cleft lip and there are patients where there is isolated cleft palate. So cleft lip refers to a congenital malformation where there is failure of fusion of frontonasal and the maxillary process. This produces a cleft in the lip. The gap in the lip not only runs through the lip, but it also runs through the alveolus and the nasal floor. That is what you call as cleft lip. On the other hand, what is the cleft palate? Cleft palate is a defect which arises due to failure of fusion of palatal ridges or palatal shelves of the maxillary process. This produces a cleft in hard palate, soft palate, or both, producing the cleft palate. Right? As I told you, clefts of lip and as well as palate, they can occur isolatedly or they can occur in various combinations along with other congenital defects in the patient. Other congenital defects which have been found associated with cleft lip and cleft palate include congenital heart diseases and some CNS defects in the patient. Remember that CNS defects are relatively more common with isolated cleft palate. Now, what is the epidemiology of cleft lip and cleft palate? These defects are more common in Asians as well as Native Americans, but they are relatively rare in the African population. They are more common in males, especially cleft lip is found to be significantly more prevalent in males. Isolated unilateral cleft lip is more common on the left side compared to the right side. An isolated cleft palate most commonly occurs in the midline. Rarely it can occur on one side of the face. Now there is a defect called as U-shaped midline cleft palate. U-shaped midline cleft palate tends to occur associated with a syndrome called as Pierre-Robin syndrome. It is a part of the micrognathia small jaw complex seen in these patients. There is another defect called as submucal cleft palate, which is not overtly visible, but it is indicated by a bifid uvula. Sometimes partial separation of the muscle with intact mucosa or a palpable notch at the posterior part of the palate are other clues that the patient is having a submucosal cleft palate. And remember that cleft lip alone is found in 15% cases, cleft lip plus cleft palate are present in 45% cases, and cleft palate alone is found in about 40% cases. Now coming to etiology of cleft lip and cleft palate, the etiology described in them is multifactorial, and if they follow a genetic sequence, they are found to have a polygenic inheritance. The cleft lip and cleft palate can be either syndromic or they can be non-syndromic. Among syndromes, more than 400 syndromes have been described in these patients. First of all, let us talk about the non-syndromic cleft lip and cleft palate. Non-syndromic forms can either be non-genetic in nature or genetic in nature. So, non-syndromic, non-genetic causes will include maternal smoking, maternal alcohol, and maternal exposure to teratogens, including drugs like isotretinoin and anti-epileptic agents. On the other hand, non-syndromic genetic causes will include mutations or abnormalities in TGF alpha as well as RAR alpha gene mutations. Now, a potential thing which can be asked in Vivas and even in your super specialty entrance exams are, what are the common syndromes associated with cleft lip and cleft palate? I already told you that about 400 syndromes can be associated. Majority of these syndromes, with some exceptions, they are autosomal dominant. So the common syndromes where cleft lip and cleft palate occur, they include Dye-George syndrome, Waardenburg syndrome, particularly type 2A variety. They occur in Treacher's-Collins syndrome. They occur in Zollinger syndrome type 3. They are a part of Van der Woode syndrome. They also occur in CLP ectodermal dysplasia syndrome. And there is a thing called as Gorlin syndrome, that is basal cell nevus syndrome, where they are often found.